Leslie Markham, who is our regional clinical director. We have Jamie Phillips, who is our regional nurse director, and Jennifer Vidito, who is our regional dietary director for Eating Recovery Center. So thank you guys so much for joining us today and presenting on the Mastering Collaboration Across Levels of Care.
Thanks, Yolanda. Okay, I'm going to start us off. Let me share my screen here. This is always the real tricky part, just to make sure that I don't share everything else on my screen. Okay, let's see. All right, Yolanda, can you see it? You can?
Yes.
Okay. All right, we will get started. So Yolanda introduced us. I'm a psychologist, and I'm, as Yolanda said, the regional clinical director at Eating Recovery Center for the South region. We're going to talk today about mastering collaboration across levels of care and really the importance of a multidisciplinary team. So we have a lot to cover. I'm going to go as quickly as I can through this, and Jamie and Jennifer are going to introduce themselves once they start taking over and talking as well. First things first, we don't have any conflict of interest here. There's no financial relationship that exists. So our learning objectives today are really that we want you guys to understand the importance of the multidisciplinary team and recognize that there is value from many different disciplines being involved in the treatment of eating disorder. There's advantages to taking that approach. There are challenges and barriers that come up, which I'm going to talk about briefly, and to be able to understand how a multidisciplinary team approaches specific clinical challenges relating to eating disorders. Okay, eating disorders in general, they are incredibly complex. I think just mental illness in general is complex, but then eating disorders, there is a lot that goes into the onset of an eating disorder. We don't like to talk about one thing that causes an eating disorder. We really like to look at it from a biopsychosocial model. There's biological things that happen, psychological things, and social things that can contribute to this perfect storm in the onset of an eating disorder. You see all these little bubbles here around the eating disorder bubble, genetics and temperament. Those are, and puberty is on here. Those are things that we can't really control, right? We don't get to choose our genetics. Our temperament is pretty solidified by age 3 or 4. So that's not something that we get to touch or choose. Puberty, when someone hits it, is not decided by the treatment team by any means. And so those are things we can't really touch. With a multidisciplinary team approach, though, we can look at things like emotional avoidance, life stressors, social and cultural factors, family environment. Those are things that we really can focus our time in. But this slide really is to showcase that eating disorders are incredibly complex, and oh, hold on, let me get all these up here. And there are psychological things that play a huge role. We oftentimes, that's my lane, right? I'm a psychologist, and the clinical piece is what I'll be talking about. The eating disorder diagnosis is really an umbrella diagnosis where what I mean by that is that there are other co-occurring diagnoses going along with an eating disorder. So we have anxiety, depression, impulsivity, low self-esteem, OCD, substance use, self-harm, these areas here. And then there's physiological things that happen as well that my colleagues are going to speak to a little bit more later on in the presentation. We have things like loss of menses, hypoglycemia, gastroparesis is one we see all the time, osteoporosis, electrolyte abnormalities, and the list can go on and on and on. When assessing for an eating disorder, what are the things that should be considered? The assessment should include medical stability, so vitals, lab work, blood sugar levels, what is their weight, and there's APA guidelines to help with the different levels of care and the criteria that meets the different levels of care. The psychological stability, is there safety concerns? Is there suicidality at play? The ability to manage their behaviors, their food intake, their exercise, what level of motivation do they have? Is it internal motivation, which many of our patients do not have, or is it more external motivation? And then what resources and support are there for the patient as well? What we do know is that when assessing for eating disorders, there's many different levels of care, right? We have the inpatient and residential level of care, which are the higher levels of care. That is where medical stability is needed. That's where the multidisciplinary team really comes into play uh, in a different way. Oh, thank you. I was like getting feedback in a different way. And then we have the partial hospital program, which is for our program 7 days a week, 8 to 10 hours a day. And then you have IOP, which is a step down there too. And then outpatient. So we need to understand what is going on from a multidisciplinary lens here to assess for appropriate levels of care. We need to do this because, as I said, eating disorders are really complex. Those with eating disorders are likely not motivated for treatment, and we expect to get pushback and resistance based on when we're recommending higher levels of care. So it is important to work together as a team. What's really needed is this multidisciplinary team. And the textbook definition here, a Webster definition, um, here is basically that it's a team of professionals with different specialties to come together to improve patient care. A more extensive definition here, I'm not going to read this to you, you can read it yourself, but I want to point out the word that is highlighted. It's that coordinated word. The big question is, are we really working when treating an eating disorder from a multidisciplinary team approach? We know that we all want to do that, but we also know that there can be challenges with that. With an with eating disorder treatment, what we are talking about when we're referring to the multidisciplinary team is this. The treatment team members can include a psychologist or therapist, family therapist, a dietitian needs to be on board, nursing in particular at the higher levels of care, nurse practitioners, psychiatrists, primary care providers. We also have medical consultants and behavioral counselors and parents and caregivers too. I want to point out that we really view the parents and the caregivers and family members that are involved as a part of the multidisciplinary team. We need them as a part of the team because we need their help, right? We need them alongside of it. Very old train of thought is that you remove the person from their family system and treat the eating disorder. But that's old train of thought for a reason, because then once they discharge, who are they going back to? They're going back to their family system from which they came. So they really have to be a part of the team. So is this reality or wishful thinking? I think it's a combination of both. There are times where it's not always a reality to utilize an entire multidisciplinary team when treating an eating disorder. However, we want to stress and talk about how important it is to strive for this. So pulling this slide back up, I want to talk a little bit about the ease with which you can use a multidisciplinary team based on the levels of care. Obviously, it is easier in higher levels of care. It's harder in outpatient treatment. So, I mean, in inpatient and residential treatment, there's doctors, nurses, behavioral techs, program therapists, dietitians, therapists, and they all work under the same roof. So their ability to collaborate and talk to each other, they're in meetings together, they're sharing patients. So it's much easier. Once you get to IOP or outpatient treatment, it becomes more difficult for obvious reasons, right? They go and they see a therapist, and then they go and they see a dietitian, their psychiatrist. But all of those people need to still be communicating and talking as well. So briefly, I'm going to touch on the clinical lane, my lane, and what's involved there. And then we're going to go through a case example to highlight the need for the multidisciplinary team approach and some challenges that can come with that. Clinically, for my lane, we do individual therapy. We make that a priority. And within that, there's assessment happening, stages of change, addressing motivation, emotion processing and regulation. We also really recommend family therapy because there needs to be education done about eating disorders and about how to best support their loved one and how to help them with their emotions and also help them interrupt their behaviors. There needs to be skill building. And then there also needs to be some work going on if they have their own blocks or things that impede their ability to support their loved one in the best way. Obviously, the clinical lane is part of the multidisciplinary team. They work very closely with outpatient providers. If you were to refer somebody up, we're going to be working closely with that outpatient provider, with dietitians, nursing and higher levels of care, doctors, etc. So I'm going to take you guys through a case example here to just talk about some of these challenges of working within a multidisciplinary team. We have Sally here, and this is not a picture of an actual patient, but I thought this slide looked better with a picture of a person on it. So this is Sally, 14-year-old female diagnosed with anorexia nervosa. Symptoms include restriction, loss of menses, hair loss, feeling cold, being lethargic, and increased anxiety and social withdrawal. There were some relevant life events and family dynamics going on. Specifically, the family relocated to a new city about a year and a half prior to her treatment during middle school. Social dynamics were pretty challenging with the move. She reported wanting to be healthier and began restricting intake at that time, seeing a change in eating behaviors. Pre-move, weight was 120 pounds, 5'1" is her height. And then when she moved, she went to see a new pediatrician, and the weight at that initial appointment was 90 pounds. So we already see a 30-pound decrease here. Parents divorced about 5 years ago. Both of them now live in the same city, and time is split between. Patient has an 11-year-old brother. As far as parents' work, mom works outside the home as a part-time yoga instructor, and dad also works outside the home as a software engineer. Sally has a history of mild anxiety since elementary school, never treated, but did impact emotional functioning in stressful situations. So the treatment history here was that she went to her pediatrician in her new town for a yearly well check. Her healthy eating was praised. The weight loss was praised at that appointment. Mom described new healthful patterns as a success, as something that she was proud of. The school, I do want to point out that when she was praised, and this is kind of our society that we live in today, but when she was praised, she was less than the 15th percentile, and she was still praised for her weight loss. So that was something that, was noted, that I wanted to note there. The school counselor was the one that called the parents that said, hey, I'm worried about this. I think you need a follow-up pediatrician appointment. When the follow-up appointment happened, Sally's weight dropped another 5 pounds down to 85 pounds. The pediatrician sent for labs at that time, made a referral to the GI doctor due to the patient and parent reports of behaviors. And that's actually really common, getting sent to a GI specialist. We see that a lot prior to people coming to eating disorder treatment. The school counselor provided recommendations for an eating disorder therapist and an RD who specialized in eating disorders. The mom was very adamant that she didn't want to pursue the recommendation here because she had worked with a nutritionist when working as a yoga instructor, somebody who promoted clean eating, and that's who the mom wanted to go with. So the ED therapist completed an assessment and at that point recommended PHP level of care due to the physical and psychological consequences of the eating disorder. At that time, parents were not on board, and neither was the pediatrician or the nutritionist that the mom took Sally to see. So at that point, eating disorder therapist is saying she needs PHP level of care. Parents are not on board. Pediatrician is not giving that recommendation, and neither is the nutritionist. So we have a difference of recommendations here. So the challenge number one here, go back. Challenge number one here is that within the multidisciplinary team, how to manage when there are varied professional opinions going on. We have the GI specialist that was on board, the pediatrician, the therapist, the nutritionist, and the parents, right? What we want to do in strategies here is to prioritize communication. What is the objective data that we have here? What does the research tell us? What do the APA criteria guidelines say? And keeping in mind that honestly, there are scary outcomes that can come from eating disorders. And so integrating all of these pieces together, prioritizing communication among the different providers, making sure that there are releases of information to be able to talk to each other and not just get report from the patient or from the parents, can help us treat the patient in a very holistic way. But there has to be intentionality behind that, in particular in the outpatient setting, because otherwise the right hand and the left hand aren't talking to each other, and there can be differing recommendations based on the report that's being given to them and based on what they're seeing. It's much easier to prioritize the communication early on, to collaborate and to make the recommendation as a group, and to talk through the differing opinions prior to making the recommendation to the patient and or the parents. Challenge number 2 here is how to engage family members, in particular of a minor in need for treatment. This is one of my favorite cartoons. It's obviously put up here in jest, but when people become parents, there's no owner's manual, right? I thought you got the owner's manual. What do we do here? There's definitely not a chapter on how to support your loved one with an eating disorder. And so it's important to keep in mind that the parents don't always know how to help. They are doing what they think is best with their current knowledge that they have. The problem is that what they want to do is not always best practice for eating disorder treatment. So, what do you do here? How to engage the family members in a way by using clinical skills is that a theory that I really ascribe to is EFFT, which is emotion focused family therapy, which talks a lot about using the clinical skills of empathy and validation, really validating the resistance that we know is going to come towards us and coming from a non judgmental approach to understand why they're not on board, why they're having the emotions that they're having, and that they're probably incredibly scared, right? That they're coming from a place of fear, and validating that fear to help them get to a place where they can maybe consider a different recommendation. For Sally's case, it's hard to understand why she isn't eating for the parents, right? They oftentimes might blame themselves. Maybe they internalize that self blame. It's the anxiety that they're having, or maybe even the fear, that keeps them from seeking treatment a lot of the times. So, parents' emotions need to be validated too. And obviously, using education, using current data and objective research, utilizing the um, APA guidelines to help inform the recommendations. That's why they're there. So back to, let's take the case example again and talk about how Sally has progressed, right? There was these differing opinions with the recommendation. There's a lack of cohesiveness here. 1 month of outpatient family-based therapy with the ED specialist was agreed upon, and a contract was created. The family was involved in the creation of that contract as well. There were weekly sessions with the nutritionist, the therapist, and the pediatrician to monitor weights and vitals. After about 4 weeks in the outpatient treatment, about 1.5 pounds were gained by Sally, which we know that progress right there shows us that she's in the wrong level of care. It's concerning. Uh, we're seeing more medical and physiological symptoms happening. There's also the behavioral stuff that's happening, continuously battling at mealtime and negotiating quantities, exercising when not supposed to be, and then co-parenting challenges that come up here too. So based after the contract was created and the month happened, there's the differing opinions. It seemed that Sally really wasn't thriving in the outpatient care, and she needed to be stepped up. So challenge number 3 is that how to make stepping up to a higher level of care happen from a multidisciplinary approach. Obviously, the collaboration is essential. We have to increase collaboration, reduce the splitting that is inevitably happening, and include clear boundaries about treatment. It's helpful here to provide the clear rationale, given what they're seeing physically and psychologically, that she's unable to interrupt behaviors, that her weight restoration wasn't where it needed to be. One thing that can be helpful when working from a multidisciplinary approach is to seek alumni support. We do that a lot with resistance to recommendations. We will seek out someone who's been with us before, who maybe struggled to get into treatment, and then, got to a point where it was like, okay, I need to go and successfully completed treatment. When people that are in outpatient hear about success stories and that it is hard, but it was worth it, it can be really, really powerful. So that's a resource that can be utilized. And then obviously, continued empathy, trust, and clear boundaries need to be there as well. A final challenge that I'm going to briefly talk about here is how to manage varied parenting styles and co-parenting an eating disorder. So not only with divorced parents, but also parents that are still together, they might have differing styles of parenting and they might have different opinions. So one thing we saw in Sally's case was that, right, the parents were divorced and they weren't on the same page with the recommendations and what to do. I did mention EFFT prior in earlier slides, and emotion coaching in particular is a skill that is associated with emotion-focused family therapy. And it's really about validation and support and helping parents and patients get to a place where they feel that extreme deep connection and validation, and and we can understand some of their blocks or their resistance to taking the recommendations of the multidisciplinary team. It's also important to identify different parenting styles to increase awareness around that so that we can come to a consensus, because when one parent is saying one thing and another is saying a different thing, that's where splitting can occur, and it can work against the multidisciplinary team, because remember, they're a part of that team. And then obviously, relationship dimensions and co-parenting behaviors too. We know that there is so much power in caregiver support. I cannot stress this enough. As you saw in the case example of Sally, many things impacted what was happening, but we need the team to come together and support the parents to be able to challenge their own thoughts and fears around their daughter's situation. Really, we need them to be empowered to do what needs to be done to get Sally the care that she needs. So just to summarize, Sally was able to get to a higher level of care after a lot of time, but it wasn't an easy road. And with better multidisciplinary team collaboration and earlier on, we could have gotten there sooner. So in this case, we can learn from it when utilizing a multidisciplinary team. And the clinical takeaways here are really that we want to treat the patient and the client and their caregivers with the empathy and compassion and setting clear boundaries. Caregiver involvement, as I've said, is very essential. We don't want to hold patients and clients in inappropriate levels of care for too long. We want to make the recommendations based on how they're presenting and what symptoms and behaviors they're engaging in. And then collaborate, and conceptualize with a multidisciplinary team, working on an approach guided by APA guidelines for higher levels of care. And if the team decides to allow a trial in lower levels of care, to contract that out with a time limit and setting clear boundaries around it. All right, I'm going to pass it off to my colleague, Jamie Phillips.
Okay, let me share my screen now so I can do that. Okie doke, let's see. Okay, are you able to see that?
I don't know, let me see.
Should be up now.
It's you need to display settings, switch the view, and then we'll be good.
Oops. Can you see it now? Sorry.
No, go to share
I see
from current slide.
Yeah. It's just on a different computer.
Screen. Yeah.
Hold on. Now I've got to open it back up. So sorry. Leslie, how about, can you just share and then I'll tell you when to do it, because it's not going to swap over for me.
Yeah.
Thanks. Okay, so we'll get started because I know we still have a lot to cover. So from the nursing lens, I'm the Regional Director of Nursing for Eating Recovery Center. And I will say that nursing plays an integral part of the multidisciplinary team and the success of patients and their recovery. But I want to focus really on communication, collaboration, and culture. Leslie, next. Thank you. So with nurses within the MDT, I will typically they are going to possess all of these skills. I mean, obviously when nurses, they first come in nursing, they're not going to have all these skills and they're developed over time. But nurses that are very effective within this model they have strong communication skills, strong interpersonal skills, problem solve, they're critical thinkers, they're able to make decisions, and they're respectful within that team. I would also like to say that they definitely recognize the contributions of others, because typically even in regular hospital settings at the higher level of care, you're going to have nurses that see multiple disciplines throughout their shift. So they really know who is kind of going to work best when. And this group will appreciate the last part, that nurses are master coordinators, but you guys definitely know what that looks like too. And you need to be a magician really to kind of get everybody together. So, all right. So communication and collaboration. At the inpatient level of care, our nurses are really involved in so much. So we have treatment team meetings, we have patient rounds, whiteboard meetings, case conceptualizations. During treatment team meetings, we're really looking at nurse representation because you have your therapist there, you have your dietitian, the psychiatrist, and they're going over cases. And really, these are just times when you're going over the basics of their case, talking about, their progress within recovery. And the nurse is bringing what they're seeing at that 24-hour level of care. For patient rounds, this is when the patient is actually involved in that kind of treatment planning for themselves. So this is a great time for the nurse to be involved in this case, because often, as Dr. Markham she talked about this a little bit, often what patients are talking about with their team 2 or 3 times a week in individual sessions may not be what's happening on the unit, right? So this is a great time to make sure everybody's on the same page. It really reduces staff splitting. And so it makes sure that everybody's on the same page, so we're moving towards the same goal. And then whiteboard meetings and case conceptualization, these are for your really complex cases or just challenging patients, and it could also be for challenging families as well. Where people can really get together. We talk about the concerns that are going on and develop a plan moving forward. At your partial hospitalization level of care and your outpatient level of care, there's less nurse involvement. However, we are still involved in daily vital sign monitoring. We're looking at lab values. And then at the PHP level of care, you are interacting with the patients a little bit more. And you're kind of just trying to recognize anything where patient might need to be escalated to another member of the team. And then in virtual and outpatient, much more patient-driven communication. And these are when disciplines are really speaking specifically with each other. So like therapist to therapist, dietitian and dietitian, and the nurse involvement is very little. All right. So again, what is the nurse's responsibility when they're going to these meetings? We are looking for nurses to be patient advocates. Again, at that inpatient higher level of care, patients are sometimes not able to, maybe they don't know what they really need, or they're unable to verbalize what they need. So this is a great opportunity for nurses to be an advocate for the patient. They're also able to speak to those things, again, what they're observing at that 24-hour level of care. And that's not just nursing, that's all of nursing support. So we have behavioral health counselors, and they're also with our patients 24/7, and they're able to speak on what they're recognizing at that higher level of care. They're able to collaborate with other teammates and develop plans of care. And often we're having to creatively think outside the box to really come up with a solution to help a patient in that next level of care. All right. Gotta click through this one a couple times. Inpatient, again, at that inpatient level of care, we've kind of gone through the things that the nurse is a part of, but then we also have daily huddles, which those are kind of in the now huddles and collaboration that we have with people working on the unit. So that looks like your nurses, that looks like your behavioral health counselors. We're talking about things such as safety concerns in the moment. We're talking about medical concerns in the moment. And often we'll have our medical providers join at the same time so that we're able to address any concern that is a little bit more time sensitive. And then I always like to tell people that caring for eating disorders is a very complex thing. I mean, we have patients, depending on how chronic their eating disorder is, depends on the complexity that they arrive with at that inpatient level of care. So we really have a hybrid, and it's very much behavioral health, and it's very much medical as well. So nurses are having to monitor very closely, maybe cardiac function. They're looking at GI issues. They're looking at maybe skin breakdown. They're obviously monitoring for behaviors, interrupting those behaviors and redirecting consistently. Their emotional support systems for patients, and then they do provide a safe environment for patients as well as team members. Okay. Outpatient, we'll kind of touch on this briefly again, but a little bit of medication support. We're checking in with the patients pretty frequently, but not as often, obviously, at the 24-hour level of care. But the biggest thing for nurses at these levels of care is that they have to be masters at communication. So that's verbal and written. And the other thing is that they have to be very pretty intuitive, and then the ability to pay attention to detail. So they're looking for signs that a patient might be struggling at a lower level of care also, and that might be through labs or through vitals, checking their weights, and then intervening at that moment. So that means communicating that to the team. And at that time, the team is able to decide, along with the nurse and the patient and the support system, if one, we're able to intervene and kind of break that, the problem right now, or do we need to escalate it to a higher level of care? Okay, and so one of the other disciplines that nursing collaborates with a ton is nutrition at the higher level of care. Jennifer and I will discuss the case a little bit later, but I'll pass this on for nutrition.
Thanks, Jamie. I'm Jennifer Vidito. I'm the Regional Director of Nutrition for ERC's South Region. And while we've just talked about the therapy lane and the nursing lane, I want to spend a few moments talking about the nutrition lane. And then, like Jamie said, we'll talk about how they all integrate together in a case. So the dietitian's role on the treatment team is to help the patient develop more structure with food, more balance, and understand what that means, incorporate more variety and flexibility, and work towards enjoying foods again, since with eating disorders, a lot of times patients will stop eating foods that they don't like or that they used to really enjoy. Okay, so here is how dietitians, which RDs stands for registered dietitians, this is how dietitians work within the multidisciplinary team at the higher levels of care, at inpatient, residential, and that partial hospitalization level of care. So there's several things that they focus on. First is they want to complete an assessment, a nutrition assessment with each and every patient upon admission, see where the patient is at nutrition-wise, and then continue to evaluate their nutritional status as the patient progresses through treatment. So at ERC, we have dietitians meet with patients twice per week. And then in addition to that, individually with the whole treatment team all together with the patient one time a week. So there's 3 different touch points that the dietitian has with the patient. And of course, if needed, the dietitian can touch base more often with the patient, especially if, say, a patient's on tube feeds or, like Jamie was talking about, very medically complex, the dietitian may be checking in more frequently than the stated amounts. Dietitians also are responsible for implementing and monitoring meal plans. What I mean by that is we want each patient to have an individualized meal plan that meets their nutritional needs in that moment. Something I tell patients and families in regards to meal plans is that it's never set in stone and always open to change, because a person's nutritional needs may change as they progress through the treatment process, because there's so much healing that needs to be done internally that the eating disorder has caused. So a person's metabolic needs may increase over time while they're in treatment. So the dietitian will design that, consisting of 3 meals and up from anywhere from 1 to 3 snacks, and will accommodate allergies, intolerances, religious dietary needs, so on and so forth. And we use the diabetic exchange system loosely as a guide to create these meal plans. And then the dietitian is also responsible for making sure the patients make all of the appropriate menu selections each week on their menus according to what their meal plan calls for. Dietitians also are responsible for collaborating with the psychiatrist and medical doctor and nursing, especially with those patients who may be in our inpatient or residential levels of care and are on tube feeds. Tube feeds are never something we go to quickly. We use them more as a last resort. The way we view them is that it's a tool if they're needed to help provide that nutrition a patient needs, if they're unable to consume food orally at a particular time. So lots of collaboration when it comes to tube feeds. Dietitians also are responsible for collaborating with a patient's family. It is so important, like Dr. Markham was talking about earlier, that we integrate the family into the treatment plan, into the decisions, into the discussions. We want to align with them and maintain that alliance. Otherwise, the eating disorder will likely try to split the team and the family. And then, oh, thank you. And then the dietitian also works with the treatment team on creating interventions, different exposures with food, planning passes, because as a patient steps down the levels of care, especially when they get to PHP, we want them to have experience eating off unit, eating away from ERC, so that they can have that practice before they go back into their life full term. And then dietitians play an integral role with determining the length of stay, because if a patient needs to weight restore, that will really be one of the deciding factors in how long the patient needs to stay to accomplish that. We can typically help a patient restore anywhere from 3 to 5 pounds a week in these levels of care. Sometimes it's hard if the patient is really struggling with their meal plan, but we try to make that weight restoration process, if it's needed, it's not always needed, go as quickly and safely as possible. And then dietitians are responsible for updating the treatment team on any weight changes that the patient has, whether up or down, how the patient's doing with their meal plan completion, about how many calories they're consuming so we can continue to monitor their nutritional state. And then if they're on tube feeds, an anticipated timeline for when maybe the tube feedings can cease. Next slide, thank you. Oh, that's weird. Okay, sorry, there's a little organizational issue with this slide, but it's okay. So in addition to those things we just talked about, the RD is going to monitor things like weights and labs, meal plan completion, nursing notes, because like Jamie said, nurses really are seeing so much of what's going on and provide so many helpful observations to the rest of the team. Dietitians will review those meal and snack choices weekly to make sure they're appropriate and make sure the patient is challenging themselves. The dietitian is also going to provide nutrition counseling and education to the patients and their support network. And they're going to help plan those meal passes and food challenges, both in and outside of treatment. A lot of times what dietitians will do is they will eat with the patient to help normalize different foods and help the patient see that the dietitian is comfortable eating the same thing that we're challenging the patient to eat. And then we can also run groups to help the patients learn more about nutrition or learn more about different cooking skills, so they have that awareness as well. So the RD's role in the IOP level of care, the intensive outpatient level of care, is a little bit different than it was when a patient was in the inpatient, residential, or PHP levels of care. And this is because at the IOP level of care, we expect the patient to return to seeing their outpatient team. So really what I view IOP as is like an umbrella over the outpatient team. So ERC's IOP program serves as an additional support to what the outpatient team is working on with the patient. So the ERC dietitian at the IOP level of care will collaborate and coordinate with the outpatient dietitian to really understand what is going on in those outpatient sessions, or if the patient did not come into treatment with an outpatient dietitian, we will help them get established with an outpatient dietitian. And then we want to make sure that we're also collaborating on site and making sure that the IOP therapist's goals are in alignment with the IOP dietitian's goals and the whole outpatient team. So lots of collaboration going on internally and externally with the two teams. The dietitian with IOP patients will meet once every other week with the patient because, again, they are seeing their outpatient team in addition to coming to IOP programming. So really the ERC dietitian serves as more of a check-in dietitian to make sure the patient is meeting with their outpatient dietitian and progressing in those sessions. The dietitian also will communicate with the outpatient dietitian regarding things like weight trends, progress in IOP, and any concerns or just changes that may arise. And then, just like in the other levels of care, the dietitian will also teach nutrition groups, parent education groups, can do cooking groups as well. Okay, so here's where we're going to talk about really how the different clinical disciplines can come together on these more complicated cases. Jamie, would you like to introduce diabulimia?
Sure. So let me turn my heater off. It's a little loud. My heater was on in here. So diabulimia. So diabulimia is basically it's a patient that has an eating disorder and they have diabetes as well. So it basically looks like they're intentionally misusing their insulin as a form of purging to lose weight. So that can look like several different things, and we'll talk about this a little bit later. So diabulimia is not really the term that we use, but it's kind of the term that will describe this type of patient. Okay, so up to 60% of women with type 1 diabetes restrict to lose weight. It's probably, studies have shown that they probably do that a little bit earlier. We just don't have all the data. But that's just kind of what it is. Sorry for the diabulimia piece. But men are more likely to over-exercise rather than restrict their diet. One of the case studies that we'll show a little bit later, this is what this patient does as well. Okay, Jennifer, you want to?
Sure. So there are lots of different emotional and behavioral symptoms that come with diabulimia. It could be any of these on the screen. I'll touch on a few of them, such as increasing the neglect of the diabetes management, developing greater amounts of anxiety related to body image. There becomes this real intense focus on exercise, and it can even be compulsive in nature. Oftentimes sleep is disrupted. Oftentimes really the pattern of a person's life changes and they'll become more isolated and avoid eating with family or going out to eat. There tends to be this fear that insulin could make them fat or make them gain weight. There also could be a fear related to having too low of blood sugars, so they don't want to dose the insulin appropriately. And there may be discomfort about testing their blood sugar levels or injecting insulin in front of others, so that can be a symptom of this as well. And really developing these overly strict food rules and a lot of secrecy related to eating and diabetes management.
Okay.
I'll talk about the physical. Go ahead.
Yeah.
Okay. So a few of the physical symptoms to go along with the more psychological symptoms can be things like A1C of 9.0 or higher on a continuous basis. A1Cs inconsistent with meter readings, potentially unexplained weight loss, nausea and vomiting, more frequent thirst and urination, multiple DKA episodes or near DKA episodes, low sodium potassium, so electrolyte imbalances, different yeast infections or bladder infections, irregular menses or lack of menstruation in females, deteriorating or blurry vision, fatigue or lethargy, dry hair, and skin as well can be physical symptoms of diabulimia.
So I can speak to the forms of insulin manipulation. So often our patients, when they come in to the higher level of care, if they are manipulating their insulin, they're going to automatically be at the inpatient level of care. We won't have them at a lower level of care because it really can't be managed. So when they come into the inpatient level of care, we are completely number blind. It's almost like you would manage a patient that was like a newly diagnosed 3 or 4-year-old with diabetes, how you would kind of look at that. So what they will do prior to coming into as manipulating their insulin is sometimes they'll have the insulin pens and they might put saline or water inside the insulin pen so it's not all insulin. They'll squeeze their injection site. If they have a pump, they may not have it. They may just have it attached to their skin, but it's not actually infusing. The other thing is they'll expose the insulin to heat, so they're trying to destroy it. They will, at times, let's say if they eat a sandwich and it calls for 3 units of insulin, they may just give themselves 1. So there's a lot of different ways that they will manipulate the insulin. So it's very important that we monitor very closely. We progress in baby steps. So when they go from completely dependent on the nursing nutrition team to where they're independent and they're going to that lower level of care, being able to function independently. Let's see, I don't know if we're going to have a bunch of time, but it's like the perfect storm. So when you have patients that are diabetic and with an eating disorder, typically what happens is they're kind of going through body changes, puberty at the age that they're